Good morning, dear colleagues. My name is Sara. I'm from Portland, Oregon. I studied in Debrecen years ago, and right now I'm working in the cardiology hospital. I would like to thank my supervisor and translational teams at Semmelweis University. And my vision is introducing innovative approaches in medicine through translational research from bedside to bench and bench to bedside for my patients all over the world. And my mission is collaborating with Semmelweis University Cardiovascular Medicine as a national leader in health for purpose of improving the health and well-being of Hungarians and beyond. I have clinical questions about the leadless pacemaker, and my methodology are as following: intracardiac leadless pacemaker, long-term safety over traditional pacemaker. It's a systematic review and meta-analysis. And the second one is the real-life patient selections and indication of the leadless pacemaker, and it's an international survey study. As a background, a leadless pacemaker is less invasive with the fewer complications. The primary advantage of the leadless pacemaker is elimination of the several complications associated with the conventional pacemaker and leads, including pocket infections, hematoma, lead dislodgement, and lead fracture. 90% is smaller than conventional pacemaker, and the future of the leadless pacemaker technology is promising. One of the beneficial applications for leadless device is in the patient with the artificial valve. As a diagram for future perspective of the leadless pacemaker, as you can see, they will use the combination of leadless with the conventional. About the first projects, the pacemaker-related infection is one of the most costly complications and has a very high mortality rate, 30 to 35%. And cardiac tamponade during and after leadless pacemaker implantation is a high-risk complication, and pacemaker dislodgement in pacemaker-dependent patient may lead to the fatal outcome. Leadless pacemakers were designed to reduce lead-related complications, and articles suggest that they are associated with reduced infection rate and dislodgement, but higher cardiac tamponade. That's why systematic review is needed. Our clinical questions is that, is the leadless pacemaker use associated with different rate of mortality, complication, and revision compared to conventional pacemaker? And as our PICO, the population is patients who needs pacemaker for right ventricular pacing, and the intervention is leadless pacemaker therapy, and the control group is a conventional pacemaker therapy, and the outcomes are all-cause mortality, complication, revision, infection, and cardiac tamponade. And our hypothesis is that the leadless pacemaker has less complication than conventional pacemaker for right ventricular pacing. We use the following database in 2nd of November, and we use the following search key. And we use the 21 full text for data extraction. We used 1 month, 6 months, 12 to 24 months of the time period for comparing the leadless pacemaker with conventional pacemaker. For 1 month complication rate, as you can see, we have 34% less complication rate in favor of leadless pacemaker. Trends is not significant. In 6 months of the complication rates, we see 56% significantly less complication rate in favor of leadless pacemaker. In 12 to 24 months of the complications, we see 59% significantly less complication rate in favor of leadless pacemaker. In 6 months infection rate, we see 63% significantly less infection rate in favor of leadless pacemaker. And in 12 to 24 months of infection rate, we see 80% less infection rate in favor of leadless pacemaker with no significant difference. In 6 months all-cause mortality rate, we see 26% all-cause mortality with no significant difference. And in 12 to 24 months all-cause mortality rate, we see 14% less all-cause mortality rate in favor of leadless pacemaker with no significant difference. And as a summary, the strength of our study, for some of these outcomes, we managed to pool lots of patients, 20,000 patients, and they are all from direct comparison studies. And the limitations would be that they are all observational study, and some of them imply the historical cohort as a control group, and the strength of evidence is not that high. And as a conclusion, the overall complication rate is significantly lower at 6 and 12 to 24 months in favor of leadless pacemaker compared to conventional, and clinically relevant at all time points. And leadless pacemakers show lower rate of the device-related infections at any analyzed time points, and significantly lower at 6 months, and no significant difference at 12 to 24 months. And all-cause mortality shows no significant difference in leadless pacemaker compared to conventional in adequately matched patient. And the clinical implication for our practice would be that our results suggest that the patient with higher infection and complication risk should receive leadless pacemaker because of the lower complication and infection rate in the midterm follow-up compared to conventional. And the implication for research is that high-quality randomized controlled trial with the longer follow-up periods, more than 2 years, needed to provide accurate data to determine the real value of this advanced technology. We submitted our article to the JAMA Cardiology, and it's under the revision. And about the second project, international survey study, the leadless pacemaker reduced major complication by 63% compared to conventional pacemaker. And per survey in Europe in 2018, the high cost of the device, 91%, a main reason of not using the leadless pacemaker in the patient. And 72% of the surveyed anticipated that increase the utilizations of the leadless pacemaker within the next 2 years. And that's the reason why to reassess. Our clinical question is that which patient population served better by leadless pacemaker versus conventional pacemaker? And what are the major barriers that patients do not receive leadless pacemaker? And the aim is that to evaluate real-life patient selections for leadless pacemaker implantations and identifying the major cause which prevent the widespread use of the leadless pacemaker technology. The hypothesis is that the high price, awareness, insurance company coverage, training, and the knowledge of the cardiologists that using and implanting the leadless pacemaker are the major barriers that of the leadless pacemaker implantations. And the technical points is that we created the self-made questionnaires, and we distributed it in the arrhythmia societies. Per Arrhythmia Society responses, they are already using, 76% of the centers are already using the leadless pacemaker, and in next 2 years, 56% of them, they anticipated that the utilizations of the leadless pacemaker will increase. And our survey is at the level of follow-up and quality control, and this is a QR code. You are almost welcome to answer also the survey questionnaire if you would like. And this is a summary. And I already presented it in MCAT, in the Hungarian Society of the Cardiologists, and the Semmelweis Symposium and Scientific Days in Semmelweis, and also at the level of lectures in the hospitals. I would like to greatly thank to all of these institutions for their support throughout our research journey. And about my personal code, one of my hobbies is writing the poems, and I wrote this poem for all of us, including all healthcare workers, all physicians, and all beautiful human beings which with their gestures and actions, they promote unity, love, care, and compassion throughout their lifetime. And my poem is A Life in Our Lifetime, celebrating light and life in the heart of the darkness, bringing life, hope, joy for all hearts in pain. Wonders at wondering, we have a universe in our hearts, and we are all one heart in the universe. Thank you very much for your kind attention.
Thank you very much for the excellent and very practical presentation, which is very interesting. To start with a few questions, I might have missed from the presentation that what is the current rate of using this leadless pacemaker in the Hungarian real-life situation? Could you comment on that? The second question would be, do you know the exact price difference in forints, dollars, or whatsoever? And have you tried to calculate what would be the price of treating an infectious complication that might have been caused by the classical pacemaker?
Okay, thank you very much for your question. Regarding the Hungarian usage of the leadless pacemaker, on 2014, the Honvéd Hospital started to utilize it and use it through my also supervisor. They were the leaders in using leadless pacemaker. Basically, since 2014 till now, about 100 patients, if I'm... Yes. Yeah, and so it's around 100 for leadless pacemaker, because the patient populations should be eligible for leadless for right ventricular pacing therapy, and at the same time, at this moment, they use the patient. They select the patients who has high comorbidity conditions. So basic, and this is one of the reasons. And the second thing is for sure the cost, as you mentioned, which that's if the patient is utilized and selected for the leadless pacemaker, it has been covered by the government, but for sure it's a higher cost for the government.
Do you know the exact number?
The million, but how much million? I think it's 1 per 50 higher, so it's 50 times more expensive than conventional.
50?
Yeah. 8 to 10 times.
8 to 10 times. So you could insert 10 other pacemaker
For the
same price of one single. Okay, and what would be the price of taking care of an infection caused by?
The infection, well, sometimes it causes mortality. And 30 to 35% of the mortality is quite high for the patients, which it is related to pacemaker associated. 30 to 35% is quite high. So basically, if we can, for the patients who are eligible for right ventricular pacing and they are in the high risk of the infections, they already had the infections from previous conventional, so it's better to use leadless, I can say.
If you were a patient who could pay for it, would pay that? Definitively, yes. And do you know what is done in the United States?
Yes, they are using it quite often, so it's more in their day-to-day practice. I think it's more, they are using it more. So per my communications with also the colleagues over there. So the leadless pacemaker is quite often, if the patient is eligible for that, they use it.
Mm-hmm. What is the reason for mortality? What is the cause of death? Do you know? Could you comment? Sepsis.
Yeah, because you know, they have this for conventional. They have this pocket, and the pocket usually
endocarditis.
Yeah, yes, but for leadless we don't have pockets, so it's already it's implanted inside the heart, so we have less chance of the infection rate.
May I ask a provocative question? Safety is, of course, a central issue here, and you presented nicely on the basis of your meta-analysis that it is convincingly better. Are you the first one to perform meta-analysis on this question?
Me? I think there are one or two of good meta-analysis, but they studied safety and efficacy in different versions. But we are the only meta-analysis that we divided the time periods for complication and infection and mortalities in 1 month, 6 months, 12 to 24 months, and we clearly presented the data in this setting. So we are the only meta-analysis at this moment.
In that sense?
In this sense, yes.
And so the added value and the added information coming out from your analysis will upgrade our understanding on the safety in comparison to what information has been already available in the literature, also on the basis of meta-analysis. Is it what you are saying?
In the meta-analysis that they already they published, basically they use the complication as a safety. But we extracted data of complications, infections, and cardiac perforations, plus mortality. So these are our added values, and I think in that sense we did a good job.
Okay. You convinced me that you did a good job. That's not the point. The question is how market ready your study is, and whether this upgrade in the level will convince also JAMA. And we full-heartedly support your effort, of course, and would like to see your success and everything. I'm just asking whether the strategy will be strong enough for that. And thank you very much.
So if I followed your presentation, you showed no difference between in mortality but in complication. But previously, just you mentioned that with not the conventional pacemaker, there is less infection. And if I understood you well, that you attributed the mortality to the infection, or I misunderstood?
Thank you for your questions. Basically, all-cause mortality, per definition, it means that patients can die for any reason. But the infection mortality, this is basically for our study. We didn't study this way, that infection mortality. But for sure, the conventional pacemaker-related infections and the mortality out of that infections per published studies is 30 to 35%. But in all-cause mortality, the patient can die out of any reason, for sure. It can be also throughout the sepsis. But as you can see, in leadless pacemaker, it's very high value in favor of the leadless pacemaker. So basically, we have very quiet, in each study, even we have 0 events of the infections.
So this is not a question, just I would like to make a comment regarding your presentation. I think you presented with the time frame 10 minutes, too many slides, and you did not explain in some instances well your slides. So that for my part, it was sometimes hard to follow. So I would advise you in the future that when you present a slide, give the time and present it, because if you just make one sentence and you change the slide, then it's meaningless. So you should spend more time with the slide and be active with the slide to show what is on the slide. Okay.
Congrats for the wonderful presentation. I would like to ask 2 things, and they are maybe in connection. I would like to ask, when in general do we expect the infection after the implementation of the pacemaker? So it's after the intervention, like like in one day, one in the next week, next month, because you showed results that there was a difference after 6 months, and maybe I would expect the infection only in the first weeks, 1 month. So yeah.
Thank you for your questions. Basically, infections can happen anytime in the patient. If it happens. Well, in the patients who get endocarditis, sepsis, it may take time to show the symptoms. And sometimes patients get reinfection because they are immune compromised, and it takes for them time. You give them a therapy, and they show the sign of the infection later after you stop the therapy. So because we are dealing with different patient populations, and if they are at the level of immune compromise, for sure they will show it later.
I can accept also the answer, of course, and that's fine, but still maybe I don't understand fully when we have the highest probability to develop an infection after the implementation of the pacemaker. 1 month, 6 months, 1 year. Can you tell me when we have the highest chance to have the infection?
For conventional?
No, for in general.
For leadless, it's quite low, but for conventional, because after conventional pacemaker, we give them a period of antibiotics therapy. So for 1 month is kind of, we are controlling it with that. But after that, you may see it during 1 to 6. So probably 1 to 6.
Thanks.
How long is the prophylactic antibiotics? What is the standard use? 1 week, and what do you give?
It's a kind of combination of vancomycins with...
Vancomycin for resistant staphylococci, I guess.
Probably. I'm not 100% sure, but it's a combination of 2 antibiotics. Yeah.
Just by watching this slide here, and the 3 studies which were included in your meta-analysis on odds ratio calculation, the event rates are quite distinct. Of course, the total numbers are also largely different, but in particular in study number 3 by Bodin et al., events rate are pretty comparable in contrast to the 2 other studies, in particular on the top, in which the number of events were 91 in the conventional arm and 0 in the leadless arm. So while including your data, did you speculate what could be the background of this relatively apparent distinction in the results here? Because just lumping them together and saying that we now include some kind of algorithm might be misleading if the standard, if the initial conditions were distinct in those studies. At least this is my blind supposition. Could you comment on that?
So basically, regarding specifically the Bodin, that was also interesting for us, that it was their finding. So, and we just reported what it was. And they just reported this. Probably it was also their patient populations and the conditions. So, compared to 2 different studies, Tijong and Cantillon, well, we have 0 infection. We just reported what they found and why they found it this way. For sure, it depends to their populations, patient groups, and center.
So I would be maybe even more provocative in the sense that you had here 3 different studies and you made a summary of the 3, but looking these data, I'm not quite sure that you can do an averaging the three study if they are so much different. So either I would not do a comparison like that or wait, find more studies, because I mean the average, looking this slide, in my mind is meaningless. Because if I look the third study and the first study as was so much different, and averaging three studies like that, I don't know what sort of conclusion.
Thank you for your points. I need to mention that we collected matched data. For sure, we had more data unmatched. So we just followed just the matched populations, which it gives more weight to our findings. And that was our purpose. If you see 3 here, we had more unmatched, which we didn't include, but we just wanted to present that because matched data has more value in that sense. And for all of our studies, we use the matched. So that's why you see less, but we extracted more data, which it were unmatched, but we just, if it was unmatched and matched, we just selected the matched one at the end for creating the forest plots.
Were these studies retrospective or prospective?
It was a combination. So the majority for sure was observational cohort, retro or prospective, both. But in the table, summary table, we just mentioned all of them, which one is which.
Shall I ask you to go back to the PICO of the first study, and I would like to ask you that at DP, could you make any subgrouping based on maybe the etiology of the why these patient needed the pacemaker? So based on that, can you make any recommendation to choose between the leadless and the conventional pacemaker?
Yeah, so for sure, if we have more publications, we can do that. And one of the things that we were thinking that maybe in future, if we have more studies to do, is patients with different comorbidities, comortalities, that they just received leadless pacemaker compared to conventional, which usually normal patients straightforward would receive it. That would be a great approach to understand also different outcomes, because let's say if you use it in the high comorbidity, comortality patients, for sure the all-cause mortality related to that is more higher. Or in the aged patients above 85. In some of the articles they used 80, 85 years old of the patients with dialysis, with diabetes, and so many other comorbidities. So that would be a good subgroup analysis, but unfortunately we don't have varieties of the publications at this moment to do this.
Thank you for the really thought-provoking presentation, because I think it's really interesting. And I have a couple of questions, but some of the questions were already asked by my colleagues. I'm also interested in, and it would have been really useful to actually produce graphs or images which show the change in all the outcomes over time to make a comparison. Because if we go to your, can you just show me the first forest plot? Like here you have 1 month complication rate. We have the rates, the odds ratios actually, and it would have been nice to see the pooled odds for both groups over time, so we can see how they run together or how they get separated, because right from this image we can't really see the odds. Maybe that could be an addition, or not anymore. We are in the phase that you can add something like that. I think it would be visible. I don't know what is the clinicians expect to see this change over time.
Would be nice.
Where to expect it, because it's doable. You have the data for that. Any idea on that?
We haven't done it. Our statisticians did a good jobs because.
No question about that. No, really. So he will be maybe angry at me if I give him extra job. The other question is that you have you told me that you could include altogether 24 studies, right?
21.
21 studies. And none of these were RCTs.
No. Basically, as we heard, they are running a RCT, randomized control trial, but it's not published yet, so we'll see it in the future.
But how did this device get a permission from FDA if it doesn't have RCT? And you told me that it is used in Hungary since 2014. So 9 years. So I guess it was first the US where they use it, or so.
FDA approved it on 2021, actually. So the
these were
FDA
all experiment. So can you just clear it up?
The
whole
FDA
thing?
approved it at January 2020. It was in January 2020. Actually, they used FDA approval, but in HomeVid they started 2014 because they just wanted to experimentally.
But on what grounds did the FDA approve it?
They had a study, actually, that study, it was in collaborations of Medtronics with
As a manufacturer.
the manufacturers, in combination with the hospitals. Dr. Schnitz also, he was running it. So basically, they did a collaboration and they published about the safety and safety of this device and how efficient it can be in the patients in right ventricular pacing. So in that sense, I think the approval came from that publication. But industrial independent RCT, they are just trying to do it at this moment.
But even industrial dependent is good. I mean, if it's an RCT, you have very strict rules how to carry out. I mean, most of the RCTs are industry dependent. You have a sponsor who pays for the whole study. So I think that would be, I don't know, at least in the systematic review part, or to include it somehow, because it's many, many years now. And I don't know when was the first implant in the US. That might also matter. So this would be, I think that's an information that must exist somewhere. How many manufacturers do you have of this? So it's the property of one company so far?
We had manufacturers like Medtronics and also Abbott, and also these two.
So you have like two
so far they just are using.
Because that might also be able to explain some of the heterogeneity that you have mentioned. And also, you mentioned infection is very important, but what is the prevalence of infection? So you told me that 30 to 35% of infections lead to death, but what is the percentage of infections for the conventional?
Thank you for the questions. Actually, it's quite common. That's why it's just something that we need to. I don't have the number, but infection rate in the patients with conventional pacemaker. That's why we use prophylactic antibiotic therapy.
Right.
Because of the pocket. But the number, I don't know. But we always, for any outcomes, the consequence is important. So infections, as long as you can treat it with the antibiotic and it doesn't cause to the death, that's okay. But if it causes to the death and mortality, that's a question. And that, because it brings so much cost, also for the hospital to take care of the patients who are in the infection phase, sepsis or something.
I agree with that.
So
completely.
we are just targeting that points.
But because we are talking about here what was mentioned in the very beginning, the price tag, and you need to justify it somehow by numbers needed to treat. So the absolute numbers also matter in that sense. And also what we realized that you didn't really find finally a difference in the mortality, which gives me the conclusion that patients just die of different reasons. So you have different infection rate, but same mortality rate, then people using this leadless will die of not infection, but something
I
else.
should highlight, thank you for the points. Actually, I should highlight, again, I would emphasize that so far the patients that have been used for the leadless pacemaker, they were high comorbidity, co-mortality patient. So it means even if they didn't die of the infections, they died because of their comorbidity consequence in the leadless.
Matched controls, right? You only used studies
yes,
with matched controls.
We used, yeah.
So that's the point of matching, that you adjust for those differences. Please.
And that at least you should make some difference on infectious complications, so they are not the same. Just having a fever or having a local infection or having sepsis, it is very different. And even if someone doesn't die because of sepsis, can have a long-term complication because of the sepsis and the low quality of life. So I don't know how much they describe the details of the infectious complications, these articles, but you should focus a bit on that.
Mm-hmm. And one more point regarding Dr. Ghare question. So as you can see, it's 40% less in all-cause mortality in favor of leadless pacemaker, even though it's not statistically significant, but still it's clinically relevant.
It's not relevant because that value is somewhere between 1/4 to 3 times as high. You always have to look at the confidence interval.
Okay.
So it can be maybe a 4th rate, maybe 3 times as much. So always look at the CI, not at the point estimate.
Okay, but but still we considered it like in the favor of the leadless pacemaker.
Yeah, but you see, okay. But always you look at the width of that confidence interval and compare it to where your effect is.
Okay.
So, this is
Okay, anyhow, thank you very much. I think we have to move forward. It was a very nice presentation, a very interesting problem.